Frequency ablation. My name is Ken Candido. I'm a professor of clinical surgery and professor of clinical anesthesiology at the University of Illinois College of Medicine, currently in private practice. Previously been a chairman of an anesthesia residency program for approximately 15 years and also ran pain medicine fellowships at 2 locations in Chicago. I have no disclosures as they relate to this learning activity, but just one brief announcement. The session is scheduled for approximately 20 minutes, but the next session here doesn't start until 5:30, and so I may go a little bit beyond 20 minutes because there's some significant information which I'd like to impart to you. Much of it will be a review, so there are some basic pieces of information here, but there's also some new information which I think is very compelling about the evidence in favor of the use of different techniques of radio frequency. We'll discuss the usual and customary uses of RFA, both conventional continuous energy as well as pulsed RFA, as well as the use of cooled RFA. And we'll talk about the indications in the spine and the extremities, and what constitutes the levels of evidence in favor, or for that matter, the lack of evidence in favor of its use. So the history of of energy use in the management of pain, electrical energy, goes back to at least 1868, or does it? How many people in the audience think that there's at least a 5,000-year history of use of electricity for managing pain? And that's true. The Greeks knew about this. We'll talk about that in just a moment. But direct current lesions on neural tissues in animals was first reported in 1868, so more than 150 years ago. And then in 1980, Nick Bogduck, who's made remarkable, substantial contributions to radio frequency, described the anatomically correct points by electrically stimulating points in the spine, both the cervical as well as the lumbar spine. This was a fascinating and very critically important piece of historical information for us going forward with the use of radio frequency. What were the actual targets? But as this paper points out, for at least 5 millennia, 5,000 plus years, we used electrical energy from fish, Narsay fish or electrical fish, to basically cure certain anatomical, rheumatological, spinal related conditions. And the literature, at least the non-scientific literature, the lay literature, is replete with many reports of the use of electricity to manage painful conditions dating back more than 5,000 years. My contributions are relatively humble, although I did contribute to the most recent iteration of the American Society of Interventional Pain Physicians, our guidelines on the use of radio frequency techniques. So if you take nothing else home from this lecture today, this is an important piece of information. What is the levels of evidence in favor of the use of RFA for spinal conditions, the conditions related to the facet joints? So for the cervical spine, after we looked at hundreds and hundreds of articles and created a systematic review and meta-analysis of this data, we found that the level of evidence is 2, which is relatively moderately strong. And it's also level 2 in the lumbar spine, but it's level 3 for thoracic radio frequency techniques. And we're talking about continuous energy. We're talking about a thermal lesion to manage pain related to the facet joints, whether we're talking cervical, thoracic, or lumbar. Levels are 2, 3, and 2. Very important information when you're making a selection for your patients. Let's talk a little bit about the basics and fundamentals, then I'll talk about the studies in support of these respective techniques. So, when we're talking about radio frequency, we're talking about low end of the spectrum of electrical energy, between approximately 1 kilohertz to 100 megahertz. And compare that to the high end, high frequency energy like a gamma ray. This is a much, much lower frequency type of energy, the lowest, in fact, on the electromagnetic spectrum. But we use this in medicine to effectively block certain nociceptive impulses and signals. And the components of our equipment are relatively simple, actually. We've got a patient who is part of the circuit. We use fundamental laws of physics, V equals IR, or voltage equals current times resistance. We have an active electrode or probe. We've got a passive electrode known as the dispersive electrode or pad. And we've got the RF generator. This is an actual picture from a patient that I was doing a procedure on last week, of course, with no name included. And the effects of diagnostic blocks are mainly transient. Amongst the many contributions of Bogduck and Lord and April, mainly Bogduck and Lord and Barnsley, Leslie Barnsley, they looked at the duration of effectiveness of radio frequency in providing analgesia. And at least for the cervical spine, They came forth with the proclamation that radio frequency techniques could provide up to 15 months of analgesia. These are landmark papers that are now more than 30 years old, but they persist up to this time. Now, we don't always get 15 months of analgesia when we perform radio frequency techniques upon our patients, but that's the target, that's the goal. That's what the earlier studies in headache patients and whiplash patients demonstrated to us, was the efficacy that had a sustainability for up to 15 months. Now we compare a conventional electrode to the cooled RF electrode, and we see that there are some varying differences about it, and that will also determine the kind of lesion which is created from conventional radio frequency application. In conventional radio frequency, for those of you who are sports enthusiasts, we basically create an oblate spheroid, which looks like an American football, or now we've got the World Cup of Rugby, like a rugby ball. Whereas the lesion that is created by cooled RF looks more like a basketball. So when you think about cooled RF, think about basketball. When you think about conventional continual energy, think about a match head or a football, oblate type spheroid, or a rugby type of ball. And so what determines how big that lesion is? Well, there are several factors. And what actually is the determinant of the actual lesion itself? Well, we're oscillating electrons or ions. We're creating agitation or friction within the tissues. So the probe itself, of course, is not where the heat source is. The heat source is in the tissues as the ions are oscillating back and forth from this frictional force applied to it. And we have the end result being, of course, thermocoagulation and protein denaturation. That's the end result of a successful radio frequency technique. When we get above about 45 degrees centigrade, we have neurodestruction, which is one of the fundamental principles of radio frequency. By convention, we use 80 or 90 degrees centigrade just to be assured that we're going to have a sustainable lesion, but 45 degrees and beyond will cause a lesion. Pulse radio frequency energy relies upon 42 degrees centigrade or less for its application. We'll talk about that in just a moment. And what determines the actual size of the lesion with conventional continuous energy is the active tip. The active tip is that part which is not covered by Teflon. It's the part of the needle. For example, if you have a 10 centimeter needle, you typically have a 10 millimeter active tip. If you have a 5 centimeter needle, you typically have a 5 millimeter active tip. That's the part of the needle where there is no Teflon to protect the needle, as well as the gauge of the needle. Those are the two major determining factors which will create and determine the size of our lesion. And that's pretty much true for cooled RF as it is for conventional continuous radio frequency as well. The lesion volume increases proportionally with the duration of the burn, but it doesn't go on indefinitely. There's a ceiling effect. So that means you can apply, and by convention we use either 90 seconds, or some people use 120 seconds. Some centers use 180 seconds, but going beyond about 90 seconds will not create a larger lesion of the targeted structure as long as the needle is held or maintained in a static position. It's not moving dynamically. Lesion size, therefore, is determined by the surface area, the length of the active tip versus the diameter, the set temperature, the duration of the burn, and this is a comparison of the cooled RF lesion compared to a conventional continuous energy radio frequency lesion. You can see that it's about 40% larger with the cooled RF lesion created. And cooled, of course, is kind of a misnomer. Yes, there's cool water circulating throughout that needle, but it rapidly turns to an elevation of temperature, so we're not actually cooling the tissues down. This is not cryo-lesioning. We're actually heating the tissues as well. And this, again, shows you the type of lesion which is created. It's more like a basketball compared to a rugby ball or a football ball. And you can see that cooled RF isn't really cold, as I already mentioned to you. There's changes with temperature and volume. This is a curve. You can compare that curve to the conventional RF and see that it's slower in escalation, but more exaggerated in its nascent nadir point, meaning it gets higher and is sustained for a longer period of time. And so in addition to the factors which control the type of lesion, the size of lesion with continuous conventional radio frequency, which are things like surface area, temperature, and time, we've already talked about that. It also, in cooled RF, is determined by the coolant flow rate and the coolant temperature itself, and the lesion is about 40% larger with cooled RF than it is with continuous conventional RF. And this is a comparison of that football shaped lesion with conventional RFA, or an oblate spheroid, or a match head, compared to the type of lesion which we create when we use cooled RF. For pulse radio frequency, some people use the term radio frequency ablation. Actually, there is no ablation when we do pulsed RF. What we're doing is we're doing gene modulation, essentially. To the best of our knowledge, we're actually not creating any sustainable or permanent changes in the anatomy of our targeted nerve at all. We're doing gene modulation, and the temperature is below 42 degrees centigrade. We have rapidly oscillating bursts of energy. And so we think that this is reliant upon CFOS and mind bomb homolog 1, but we don't really know. This is all speculative. These are all things which have been studied, at least parenthetically, in animals, but we don't have a full understanding or comprehension of the mechanism of action of pulse radio frequency. There may be changes in Rexid's lamina 1 and 2, the substantia gelatinosa in the dorsal horn. Once again, we don't know that to be true. And so what is the comparison then between thermal, conventional, continuous radio frequency versus pulse? Well, the two most important things are that the analgesia is longer acting with conventional energy RFA than it is with pulse, which is shorter acting, and the changes anatomically are more sustained with continuous energy versus changes which are not occurring with pulse. So it's not really an ablative type of procedure at all. There's really no possibility for any motor or sensory changes with pulse, and there are possibilities of both motor and sensory changes if your needle should divert off of its target and end up, for example, at the dorsal root ganglion. We'll talk about that momentarily. This is a beautiful paper that came from Europe from Menno Schleuder, Chris Vissers, and Chua. This is a review looking at pulse radio frequency and a comparison of pulse radio frequency outcomes to conventional radio frequency neurotomy techniques. And they looked at the use of pulse radio frequency for a whole host of disparate types of conditions. They looked at randomized controlled trials for a whole host of musculoskeletal and spine conditions: shoulder pain, facet pain, radicular pain, idiopathic trigeminal neuralgia, and they looked at prospective studies at pulse radio frequency. And so I'm not going to go through all of these pieces of information, but their take-home message was very succinct and very important, because when they compared the use of pulse radio frequency to continuous or conventional as far as studies went, they found that there was some compelling consideration for the use of pulse radio frequency for the dorsal root ganglion in the cervical spine. Not overwhelming, just compelling information that it might be useful. But when compared to thermal neurotomy or conventional continuous radio frequency for lumbar, zygapophyseal joint pain, and for the trigeminal nerve, pulse radio frequency did not do as well as continuous conventional energy. So pulse failed to meet the standards or the benchmarks and the kind of data that we accrued when we looked at the studies of Lord and Barnsley and Bogduck and Lord, which were really showing us dramatic evidence of efficacy long-term up to 15 months, especially with cervicogenic headache related to patients who had sustained motor vehicle accidents. You should go back and look at their original papers of 56 patients, and the duration of efficacy after double diagnostic blocks confirmed that the zygapophyseal joints were the culprits. Steve Cohen, who is presenting here this week at this meeting, pointed out some of the factors which predict success and failure for lumbar zygapophyseal joint radio frequency denervation. They talked about the fact that not only do the medial branches innervate the joints, but they also innervate various muscles: the multifidus muscle, interspinous ligament and muscle, and the periosteum of the neural arch, which is why there might be some conflicting information gleaned from doing diagnostic medial branch blocks, and they were among the first to recommend doing double diagnostic blocks to rule out the possibility of failure when the muscles were not taken into consideration. They also pointed out that the pain must be above the knee, that there must be a comprehensive evaluation and examination, and that facet loading is a very poor predictor of success with these techniques, whereas paraspinal tenderness is a high predictor of success. So if the patient has significant paraspinal tenderness on their clinical examination, you might expect them to do well with conventional radio frequency of the zygapophyseal joint medial branch nerves. And also they pointed out, appropriately, we all know this, that the MRI is a very poor predictor of whether or not the patient has a facet joint dysfunction. It may show some hypertrophic facet joints, but that is not translatable to a clinical scenario of patients who could be having beneficial results or salubrious benefit from the use of radio frequency techniques. The target is this little arrow here, somewhere between our transverse process and our superior articulating process. Some would liken it to putting a needle and causing a denervation phenomenon at the eye of the so-called Scotty dog. But remember that the facet joint is a very complex diarthrodial joint with a lot of factors responsible for the potential for causing pain. Among them are that inside the joint we have substance P, a calcitonin gene-related peptide. There are also 3 distinct types of nociceptors found within the substance of the joint itself. They include low-threshold mechanoreceptors, mechanically sensitive nociceptors, and silent nociceptors. And all of these fundamentally can play a role in why certain patients are susceptible to the beneficial effects of radiofrequency and why some patients fail. The pain referral pattern mimics degenerative disc disease. It also can mimic radiculopathy above the knee, and that's really a key take-home message, not below the knee. And we rarely, if a patient has pain below the knee, we need to have a consideration for an alternative and competing diagnosis. Radiographic studies are historically and notoriously poor at determining who may or may not benefit from radiofrequency of the lumbar medial branches. And in the absence of diagnostic features, of course, and pathognomonic radiology, which I already told you does not exist, we rely very heavily upon the benefits of diagnostic local anesthetic blocks without steroids. There's no utility for adding a corticosteroid to your local anesthetic block. An individual facet joint also, it must be reconciled and always remembered. I know in the audience we all know this. Individual facet is innervated from that level as well as the one above. Therefore, to block a single joint requires blocking 2 separate segmental nerves. And of course, there's a posterior-anterior approach for the sacral ala, the S1 foramen. It's important to recognize that these are very short nerves. So the dorsal rami between lumbar 1 and lumbar 4 are actually about 5 millimeters. And they exit the spine at right angles and have a pathway directly inferior towards the upper border of the subjacent transverse process. And the medial branch nerves, of course, run a shallow course, but they're also removed from these dorsal rami by approximately 5 to 18 millimeters, or 8 to 16 millimeters. Here we see here the distance between the nerve root and the anterior aspect of the superior articulating process, which makes our techniques of radiofrequency relatively safe because there is this margin of safety between where we place our needle cannula and the active tip versus where the needle is in relationship to the dorsal root. We're not likely, if we follow anatomical constructs and we have access to our bony anatomy, either ultrasonographically or more appropriately fluoroscopically, we are unlikely to cause any damage there. And so what we're finding here is that the medial branches, that at the junction of the superior articulating process and the transverse process, that's the target for both our medial branch nerves and ultimately for our radiofrequency neurotomy techniques. L5, the ideal radiofrequency lesioning location, is similar to L1 to L4, except that we're looking at the ala of the sacrum, which is analogous to the transverse process at the superior lumbar levels. The dorsal ramus is analogous to the L1, L4 medial branches. In the neck, the situation is not identical, and we have to deal with the fact that the medial branch nerves are held tightly in place at the waistline or of the articular pillars by tendons of the semispinalis capitis muscle. This is what it looks like from anterior to posterior. The needle tip is in the mid portion of the facet joint at the so-called scallop, or the undulating scallop between respective vertebrae. We place the probe at the center of the trapezoid articular pillar, recalling that bone, of course, is an essential target because these nerves are tightly adherent by the tendon of the semispinalis capitis. Now, interestingly, a systematic review of radiofrequency ablation and pulsed RF for the management of cervicogenic headache, which was published in Pain Physician in 2015 by Nagar and Associates, found some really conflicting information. It was conflicting because it was pretty much dogma that radiofrequency was useful for cervicogenic headache. But when they looked discriminately at these studies, and there were several, that there was limited evidence to support either pulsed radiofrequency or conventional radiofrequency for the management of cervicogenic headache. And that was really pretty much stunning to me. What they stated was that there are no high-quality studies at all to support radiofrequency and pulsed RF as effective interventions for cervicogenic headache. Now, they're not talking about neck pain from facet joint dysfunction. They're talking about a distinct entity known as cervicogenic headache. But this was compelling because for many years, many of us, including myself, used radiofrequency neurotomy to treat cervicogenic headache. The data does not support that practice, however. A more recent paper, 2021, from Pain Physician, from Orhuru and Associates, looked at the management of RF ablation and pulsed RFA for the management of headache when they targeted the occipital nerves. So this is different for managing headache pain, and they use the term cervicogenic headache in the premise of the paper and the preface to the article. 18 studies, 6 randomized controlled studies, 6 prospective, 6 retrospective, when the occipital nerve was targeted. Unlike the prior paper, this showed benefit for the use of both pulsed RF as well as continuous conventional RF for managing this type of headache, meaning headache which was related to the occipital nerve. So it's a little bit confusing. The first paper in 2015 says no go. The second paper in the same journal in 2021 says, well, it's useful if you're targeting the occipital nerves only. Let's move from the back and the neck to the SI joints. Most of us are very familiar with this as a target. The referral pattern is the same as in the facets. What we're talking about is patients who have pain in the buttocks primarily, where provocation tests, including Patrick's or Faber or Gainsland's tests, give an indication that the SI joint is the ultimate target. It's a very complex joint where at least 8 different muscles insert into the anterior and posterior aspects of the joint. They include the piriformis, the biceps, gluteus maximus, the minimus, the erector spinae, the lat dorsi, thoracolumbar fascia, and iliacus. And these muscles can be complicit in why certain individuals have aching, dull, boring type pain into the SI joint. It's a pain-sensitive joint, and it has a combination of unmyelinated free nerve endings and the posterior primary rami of L2 to S3. Some authorities would claim that the actual innervation is L3 to S3. Innervation both anteriorly and posteriorly. The volume of injection for diagnostic blocks should be no greater than 2.5 mLs. That was actually a paper that I wrote with Jacob Rauschberger from New York. We studied cadavers. We injected various volumes to determine the flow as well as the capacity to fill the joint and the ideal amount of liquid, whether it's contrast or local anesthetic injected, should be no greater than 2.5 mL. So if you're putting 5 mLs in, you're overfilling the joint, or you're flooding the area. If you're putting less than that in, you're probably not getting sufficient amount of coverage for the nociceptive fibers found in the SI joint. Jacob and I published that paper about 10 years ago. There's a diffuse innervation of the joint. Anteriorly, we have the lumbosacral trunk and L2 through S2. Posteriorly, we have the posterior primary rami of L3 down to S3. The radiofrequency technique has evolved over many years. One of my great friends, who is the chief of pain at the University of California, Los Angeles, F. Michael Ferrante, he's the former president of ESRA, many of you know him. He created a strip lesion directly inside the joint using 3 distinct needles placed at the superior, middle, and inferior poles. And he published his results in the Regional Anesthesia Journal, but he never studied the efficacy compared to any other technique, so we don't really know whether this technique actually works. Then there was a lateral branch technique of Dreyfus, which was much more complex, but did not target the actual joint itself, but actually the lateral branch nerves. Cooled RF has efficacy in terms of many individuals and case reports and some prospective data now at L5 medial branch, the L5 dorsal ramus, and the lateral branches of S1 to S3, showing some compelling evidence in its favor. And this is a lateral positioning showing that it's important to make sure that the cannula are actually sunk at least 2 millimeters in a gap off of the bone to be successful. So thermal or pulse, cooled RF, you can take your pick. The data seems to indicate that cooled RF may be superior to conventional continuous energy radiofrequency for managing pain, which has been proven to be responsive to diagnostic blocks. And then along came Jingao Chang and Rick Rosenquist from the Cleveland Clinic. Most of you know them. Rick Rosenquist is another former president of the American Society of Regional Anesthesia, also a good friend of mine. And they developed a brand new technique. They published this report in 2016, looking at the use of bipolar energy for SI joint, and they compared the results head-to-head with the use of cooled radiofrequency. And they found that this bipolar technique, using multiple cannulas, it looks very cumbersome by virtue of all the needles that they've placed in, but it's actually much faster to complete than cooled RF. In fact, they said that there's a decrease in X-ray exposure by more than 80%. Operating time is reduced by more than 50%. And the cost is cut by about $1,000 per case using this bipolar technique to address radiofrequency pain that's been responsive transiently to the use of local anesthetic diagnostic blocks. And they compared directly here their bipolar radio frequency technique out to 12 months. So this is a full year study compared to cool RFA. You can see that there's a dramatic difference in terms of efficacy and responsiveness with the bipolar technique. Let's talk a little bit about the innervation of the knee and about some of the techniques which are useful in many cases to provide analgesia of a sustained benefit using radio frequency energy. The nerve supply is known to all of us: femoral nerve, tibial nerve, the common peroneal nerve, and the obturator nerve. Classically, we've blocked at least 3 of these targets using radio frequency, and there are a multitude of ways to do that: continuous, conventional energy, pulsed radio frequency, cooled radio frequency. Many people are leaning now towards cooled radio frequency of the genicular nerves because the data seems to be staggered in favor of the use of cooled techniques. So we're looking at the superior lateral, superior medial, the inferior medial geniculates, and there's also an infrapatellar branch, whereas most authorities would caution against lesioning the inferior lateral geniculate nerve because it's too close to the common peroneal. And the targets are as seen by the wires and the red arrows. And this is an anterior, posterior, and lateral approach showing the appropriate needle placement for geniculate nerve radio frequency. Again, there are many ways to do this: pulse radio frequency, continuous conventional energy, or cooled RF. Infrapatellar branch, deletion of nerve from the rectus intermedia supplies the subpatellar plexus. That's another one of the targets that some authorities would say has to be included for full efficacy. Zach McCormick, and again, here's a paper from Steve Cohen and another good friend of mine, Dave Walega, who was just until recently the chief of pain management at Northwestern University, published last year, 2 years ago, in the journal Regional Anesthesia, Technical Considerations for Improving or Optimizing Outcomes. A very nice paper in RAPM, and they talk about some of the pitfalls associated, why we miss our targets in many cases and why these blocks fail, and it has to do with the depth of needle placement and making sure that the needles are firmly adherent to bone prior to putting the electrical energy onto the targets. They also went through the very complex anatomy. It's a great review paper. If you have time, I encourage you all to look at it because they show all the variations and pathways of the respective nerves of the geniculate to the knee innervation anteriorly. Now, Leo Capurel, formerly of Cleveland, looked about cooled radio frequency and its effectiveness in the management of chronic knee pain, and they came to the conclusion that cooled radio frequency was superior to conventional techniques because it provides up to 12 months of at least up to 12 months of analgesia following the use of application of cooled RFA for chronic knee pain. Another paper from Lyman looked at cooled radio frequency and found 24 months of analgesia in the vast majority. In about 2/3 of patients, 63% of patients had up to 24 months, 2 years of sustained analgesia. There was a drop-off in terms of the population of patients with sustained benefit, but this is the paper which I frequently quote because it has the highest level and the longest duration of follow-up in terms of safety and efficacy. Here's a meta-analysis of all randomized controlled trials looking at the use of continuous radio frequency techniques for managing knee pain, and what they actually showed was a very sustained benefit using head-to-head comparisons, meta-analysis, systematic review, that not only were pain scores improved at 4 weeks, 12 weeks, and 24 weeks, but also the Western Ontario McMaster University scores, the WOMAC, for disability indices were also improved. So not only was pain improved by the use of radio frequency of the geniculate nerves for up to 12 weeks, but also improvement in functionality. So it wasn't just looking at VAS scores. The hip is a complex subject. I'm going to complete my discussion talking briefly about the hip and just a little bit about the shoulder or the upper extremity, because we have no data. We really don't know whether or not radio frequency techniques, whether it's pulsed, conventional, or cooled, actually work for hip pain. But there are some investigators pursuing this on an active level. And there's a complex innervation of the obturator of the femoral sciatic nerve. The reason why we haven't undertaken this more aggressively is that the major targets for therapeutic radiofrequency denervation lie deep to the important neurovascular structures, and so you've got to be extremely rigid in your approach to ensure symmetry of the obturator foramen under fluoroscopic imaging. This is not a technique which most people would recommend using ultrasound to guide the needle pathway. Center the C-arm on the femoral head, make sure there's no movement. Place the needle below the incisura and make sure that the RF probe pathway is as described in this technique here. progress of the probe in the final position, and there's radio frequency of the femoral articular branches. Again, the data is extremely limited with the use of radio frequency techniques for hip-related pain, but it is accruing, and I anticipate within the next 5 years having a greater body of evidence in favor of these techniques. Finally, the utilization of radio frequency management techniques of upper extremity pain, including of the suprascapular nerve. We have no real data as to whether or not this is superior to local anesthetic corticosteroid blocks or other techniques, but the data, once again, is starting to accrue. This is a brand new paper just published 2 months ago in the journal Pain Physician. So people are looking at data and trying to come to conclusions about the efficacy for shoulder-related pain, which has been recalcitrant and unresponsive even to surgical interventions. So is there any difference in our outcomes? Well, the level of evidence, as I started out this discussion with, was for radiofrequency ablation, neurotomy techniques. For the cervical spine, we have level 2 evidence. For the thoracic spine, we have minimal evidence. It's considered to be level of evidence 3. For the lumbar spine, we have levels of evidence 2. Pulse radiofrequency, according to that great paper of Menno Schleuder and Chris Vissers, is not as effective for lumbar medial branch or the trigeminal nerve as continuous conventional energy is. The evidence is very limited for radiofrequency for cervicogenic headache, at least according to one meta-analysis published in the journal Pain Physician going back to 2015. Bipolar radiofrequency, according to the paper of Rosenquist and Chang, may prove superior to cooled radiofrequency when we're talking about pain of the sacroiliac joint. And we know that cooled radiofrequency now, by several studies, can provide sustained benefit for knee pain for up to 24 months. Otherwise, there's very limited evidence for the use of any of these techniques for pain of the hips, shoulders, and other parts of the body. So I hope that this has been some compelling information. Some of it's been just a review of anatomical constructs and of the properties of what radiofrequency is all about. But I hope that this will be something you can take back to your respective practices and utilize in your own clinical pain management symposia, as well as in your clinics and your offices. And I thank you for your time and attention today.